So 1 millimeter and 2 contiguous leads to be a true STEMI, we can absolutely be fooled if we're just using the rule of thumb. Absolutely be fooled, okay? So let's talk about some of those things. Sometimes even cardiologists are going to be fooled. Sometimes you guys have all heard about the patients that go into the cath lab and they don't find anything, right? So when we talk about diagnosis and you get the blowback of, no, we don't diagnose because, you know, we can't possibly be right. Cardiologists diagnose things enough to take them into the cath lab and they're wrong sometimes, right? So not necessarily comparing us to cardiologists, I'm just making the case that we do diagnose. So anyway, here are some imposters that we'll see out in the field. Quickly, a couple questions that came up throughout me teaching this class before were pacemakers. Can we do 12 leads? Can we get an accurate picture of a STEMI for someone who has a pacemaker? Right? We'll talk about that. If they do have a pacemaker and they're complaining of chest pain and they look as though they're possibly having an MI, do we even do a 12 lead on it? Doesn't matter. And then last, STEMI imposters. So quickly, let's talk about pacemakers real fast. What are your thoughts on someone with an active pacemaker? Is it even worth doing a 12 lead on? What do you guys think?
Depends if it's ventricle facing or atrial.
Okay, let's say it's a ventricular. Is it even worth it?
I've been told no. By the
So you're told no?
physicians.
Okay. What do you guys think? We're in a 12-week class.
Yes.
Perfect. Good. Good answer. So just like Nick was saying, some people are going to say, so I read a whole bunch on this, and a lot of cardiologists were saying, don't even bother. It's not going to tell you anything. Some cardiologists are saying, absolutely do it, because A, it's not going to hurt, right? And B, it can tell you something. It can tell you something, right? So normal baseline for ST elevation, 1 small box, 1 millimeter, right? With someone with an active ventricular pacemaker, if they have more than 5 small boxes, so 1 big box of elevation, if they have that, then it can be indicative of a STEMI. It can be, okay? So my theory on this is we might be wrong, but we're not hurting the patient by doing a 12 lead if they have a pacemaker, right? And it can be helpful. Might not be, but it can be.
I've actually seen ER doctors that when we do give them that EKG, they want to see an old one because you know if that was baseline.
Yeah.
Okay, well let's see this one with a pacemaker. Let's see if it matches the baseline or
Right.
there is actually.
So yeah, so hopefully by doing that 12 lead, you can give them that comparison. So in the future, if you guys encounter any of these patients, don't hesitate to do a 12 lead. Even if the doctor throws it over his shoulder and says this isn't going to help, it doesn't hurt. Okay, so do a 12 lead. Okay, that's pretty much it. STEMI imposters. Based on your understanding, I know you guys have all done this before. You guys have all seen the STEMI imposters. What are some of the ones that are common?
Left bundle branch block.
Left bundle branch block is a big one. Another one, ventricular paste, right? Absolutely an imposter, okay? Pericarditis, pericarditic tamponade, and LVH, left ventricular hypertrophy, okay? Those can all be imposters. There's probably some other ones that we're not going to talk about, but these are some things that out in the field, if you guys are looking at the 12 lead, you're going, holy smokes, there's ST elevation everywhere. Just keep in mind, it could be one of these, and if it is, we're still treating it like a STEMI, right? Okay. Just be aware that these are some of the issues you could be facing out there. So let's look at this. Kind of difficult to see. Just
Yeah, the white ones.
does that make it easier?
Mm-hmm.
Okay. Look at 2-3 and AVF. Do we have ST elevation?
No, and 2, 3,
No.
maybe, yeah.
Not so much in 2-3 or AVF. In fact, we have that negative deflection when it should be a positive deflection. So what do we know about 2-3 and AVF? What do we know about this person's heart right now, just by looking at that cardiac history? Cardiac history, right? Do we care about why they have a cardiac history? Doesn't change our treatment, doesn't matter, they have a cardiac history. Let's look at V1, 2, 3, and 4. ST elevation?
Yep.
Yeah, so right now we know this patient is having, anterior septal, right? Okay, let's look at V5 and V6. Do we have ST elevation? Not really, right? How about 1 in AVL? Do we have ST elevation?
Yeah.
Yeah, do we have it in 2 contiguous leads? Nope. So, based on the rules of thumb that we already talked about, and you guys identified it already 20 times, we would call this anterior septal, right? Okay, here's the problem. That's a left ventricular hypertrophy. So I was reading this thing on how to identify LVH versus anterior septal. I don't get it, so I'm not even going to try to share it with you. Because honestly, there's a crazy way of looking at V1 and 2 and figuring out the elevation of the ST elevation, and then looking at 5 and 6 and subtracting the and then adding it together and figuring it. It doesn't matter for us. Okay, it doesn't matter. So most likely, and I hate to say this because I feel like I'm backtracking, but most likely, hopefully, your monitor will pick it up. Okay. And we're going to be treating signs and symptoms, and we're going to be looking at the patient in order to figure out whether or not we're going to treat this by protocol, right? Okay, but for purposes of looking at the rules of thumb, it's important that we recognize we can see this when it's not actually a STEM. Okay? T3 and AVF, do we have ST elevation? Looks like it, yeah.
Mm-hmm.
Yeah. What about, really hard to see, V1, 2, 3, and 4? ST elevation?
Not inverted.
Yeah, inverted.
Yeah.
Also, 2, 3, and AVF are also inverted, so what do we know about the patient?
Cardiac history.
Cardiac history, right? So that's a right axis deviation. Do we care about right versus left axis deviation? Do we care? Doesn't matter, they have a cardiac history, right? So what else do we see? Little spikes, right?
Yeah.
So does it make sense that they have a cardiac history if they have?
Pacemaker.
That makes sense? Ventricular pace rhythm, you're going to see a STEMI. Okay? Is this really a STEMI though? It might not be.
Could be.
It might not be. Or would we still want to do a 12 lead?
Signs and symptoms.
Yeah.
Basis.
We're gonna probably base this all off the way that patients present. Is that clear? Hard to see, huh? 2, 3 in AVF. We see that negative deflection, right? Cardiac history. Do we see ST elevation? Yeah, it's kind of hard to see, but yeah.
It's got a bundle brain.
B.
And nice, nice. 2, 3 leads 1, 2, 3, 4. Do we see ST elevation?
Looks like maybe 3 and 4.
Yeah. How about B5, 6, 1 and AVL? Really difficult to see. Anyway, you get the point, right?
Yeah.
STEMI? Okay. Ventricular pace. We see little pace rhythms. So 2, 3 and AVF, negative deflection, makes sense that they have a pacer. Cardiac history. 2, 3 AVF. I'm not going to run you guys through it. Do you see little pacer spikes?
Uh-huh.
Ventricular pace.
Yeah.
What else do we see that you picked up in V1?
Bundle branch. Oh wait, in V1?
V1. Yeah.
Yeah, he has a
Yeah.
branch. Mhm.
Yeah.
Yeah.
Got a bundle
2, 3 AVF. Do we have ST elevation here?
branch.
Yeah. How about V2, 3, 4?
Yes.
Yes.
V5, 6?
Yes,
Lead
one.
1 in AVL?
Yeah.
Yeah. Everywhere, right?
Before you go
Okay.
on, I have a question.
Yeah.
Like, if you look at all the tracings for each lead there, the amplitudes are all kind of comparable.
Right.
And if you went to that previous one, in the V1 lead, I think, no, then one more back. Yeah, the V1, there's almost no deflection there. I was just wondering, could that just be something as simple as lead placement?
Thank you. Yep. Can be. Absolutely.
Or maybe not?
Yeah.
Yeah.
Oftentimes it's lead placement, right?
Okay.
Yeah, but a lot of times it's just their bundle branch blocking their perfusion. And a lot of times they look pretty scary sometimes because they don't have anything hardly
Mm.
showing.
It was just curiosity.
They have a bad
No, good question. Thank you. Is this where we left off?
Yeah.
So basically ST elevation everywhere, right?
Yeah.
Okay, so we would say, going back to that Widowmaker thing, this person is really in bad shape, right? Could be pericarditis, okay? So the way that I think of pericarditis, here's another way of looking at it. So ST elevation, pretty much everywhere,
Yeah.
except for AVL, right?
No?
We see ST elevation everywhere, right? Okay. So we look at the pericardium, the little tissue surrounding the heart. Okay. If you think about it, if it gets filled with fluid, right? So blood, pus, whatever it is, from bacterial, viral, from trauma, whatever causes that, wherever that fluid is touching the heart, you're potentially going to see a stem. Okay. So if that whole pericardium was filled with fluid, you'll see STEMI everywhere, right? If you have the fluid buildup on 2, 3, and AVF side, on the inferior side, that's where you're going to get your STEMI. Does that make sense? Wherever that's touching is where you're going to see the elevation change. Okay? So again, it goes back to your ability to properly assess the patient, whether or not this is pericarditis or it's a legitimate heart attack. Okay? So bundle branch blocks, this is a really common one, a really common mimicker. Easiest, quickest way to figure out whether it's a left versus a right. Think about it like a steering wheel. Okay? Have you guys all heard this method before? Okay, think about it like a steering wheel, okay? When you turn left in your car and you want to do your little signal, which way are you pushing the signal button?
Down.
Pushing it down. You're pushing it down to go left, right? So if you, in V1, if you see the little bunny ears going down, it's a left bundle branch block, okay? In V1, if you see the bunny ears going up, you're making a right turn and you're signaling going right. Does that make sense?
Mm-hmm.
Okay.
That's a good way to remember.
So, just like a turn signal. So look at V1, and if you see the bunny ears going up, it's what?
Right.
Down is left. So that's commonly how it's going to look. So right bundle branch block, bunny ears going up, it's a right, bunny ears going down, left. Here's why. So electrical impulse gets blocked on that right side, right? So something is causing that right bundle branch block to infarction or previous damage or whatever it is. Something is blocking that bundle branch, okay? The electrical impulse comes through, comes across. So which part of the heart is this going through? Yep. So it's going towards V1, right? Okay, so what should happen with the deflection already at this point? Should go up. So in right bundle branch, it starts going up. The left side depolarizes, so the electrical impulse is going this way. So what should happen to the electrical impulse? Over here. Goes down. Now the right side, because of this little delay, the electrical impulse is finally making its way through here. So what should happen over here?
Go